not at that class? Can I? How about that?
Do we have any courtesy from the floor? No? Can we call the Human Services meeting to order? Do we have any courtesy from the floor? If you come up to the microphone, state your name and where you live, and you get 5 minutes, if you need it.
My name is Victoria Black. I'm a resident of Northampton County in Plainfield Township. Okay. On June the 6th, 2009, two of my grandchildren came to visit, but the need for them not to return became evident. Soon after began our involvement with children and youth. In the past, they had been very helpful and very supportive of the family's needs to protect the children. However, the past few years, there have been many changes as to how issues are dealt with. In an effort to get some answers to my concerns, I spoke with Senator Mario Scavello. Children and youth had told me that Braden, my grandson, and I have a voice, but they neglected to tell me that we have a voice that no one hears. Beginning my follow-up with Senator Scavello's advice, I called Kevin Dolan and left a detailed message, however received no callback. Next, I contacted Matthew Dietz and promptly received a return call. He said he would speak with Susan Wondolowski, I hope I didn't pronounce that wrong, and was told that a supervisor would be reaching out to me in 2 to 3 days. I got that mixed up, and that didn't happen, but about 10 days later, I called back, spoke to Mr. Dietz, who at that time made me aware that a supervisor did reach out to me, but that was not the case. Thinking I was going to get a call back from Ms. Wondolowski, I stopped at Emmerich Boulevard last week to see if I could speak with her if she was available. But instead, I was given 3 reasons why I couldn't wait by the receptionist. Children and youth are making family life-changing decisions based on statements, not facts. Fortunately for me, Senator Scavello and Matthew Dietz did hear my voice. Thank you.
Thank you. Are there any other comments from the floor? Okay. We have a report from Veterans Affairs.
Good afternoon, everyone. There are some familiar faces here. Good to see you guys. Alrighty. I'll be reporting on 5 bullet points. The first bullet point is the community outreach events that I attend. When I am invited, I make every effort to attend these community events. They can include senior fairs. A few weeks ago, there was a senior fair which was out at Scott Park right here on Larry Holmes Drive. I did attend that. So if I can make it, I will be there. I will not be I will not attend one in the first week of October because this is the second bullet point. I have mandatory training in October, the first week of October, the 1st through the 4th. This senior event is being held by Senator, forgive me her title, Marsha Hahn. State Rep, Marsha Hahn. I apologize. But unfortunately, it's on the 4th. This training is in Erie. That training will end at 12 in the afternoon, and that's a 6 to 7 hour drive. And it's being held from 10 to 1, so obviously I'm unable to attend. But rest assured that I do attend these when invited. Another bullet point is the Lehigh Valley Chamber of Commerce. They started just recently with a brand new program. It is called, and forgive me, they call it the Greater Lehigh Valley Chamber of Commerce, Veterans and Military. For some reason, I don't have that last word. But their goal is to not help, no, I'm stating this incorrectly. Their goal is to educate employers of the greater Lehigh Valley on how they can hire veterans by understanding what their jobs are while they were in the military, to teach them how they can translate what they did in the military, which can transfer over into the civilian world. Right now, it's in the very early stages. It literally just started maybe a month or so ago. There are a lot of organizations that are there, and everyone's on board, myself included, as well as my counterpart in Lehigh County, Thomas Appleback. He's there as well. So it will take a while, but they're all on board, and they really believe that this can be an easier access or transformation or transfer over their military skills into the real world and how it's applicable in the civilian world. The next bullet point, it's rapid rehousing. The Human Services Department of Human Services did receive a fund, which I'm sure you're all aware of, to help those in need directly through the county itself, through Human Services, instead of having to go through other agencies. I was able to help 8 veterans to stay in their homes, which was very important, or pay past utility bills. It was important to do this because...
Can I stop you just a minute? Can you explain a little bit more about what the funds are or what they could be used for? It's called rapid remodeling?
Rehousing.
Rehousing.
Mm-hmm. Which was a grant that the ECD was able to get Human Services. But not only for veterans, it's for anyone in need, any county resident in need.
But you're able to parlay this into services for veterans?
That is correct.
Okay.
That is correct. And this program has worked wonders because the process of getting a veteran services from either the state VA or an organization such as Wounded Warriors is more intense, and it takes them weeks to even give a decision. So now you have those that are waiting, hoping they're going to receive funding from one of these other organizations. And the last thing they want to do is wait 2 or 3 weeks, and then it's a negative. They didn't qualify for whatever reason. With this program, with my supervisor, Susan, we were able to circumvent that. And if they still needed to qualify in terms of character of service, obviously the state or the federal VA doesn't help those that have a dishonorable or other than honorable. So I felt it was necessary that we had to follow that as well at this level. Because if they don't qualify for federal or state, then it's not right that they would qualify for county when, if the money is spent, those who are more deserving or have a discharge favorable or honorable would not be helped because the funds were used for someone who had a dishonorable or an OTH. So, but this program has been a godsend to to the veterans that did help, and it was truly appreciated by us in the Department of Human Services. The next and final is I have here copies of, there was a program that was in the veteran system of my computer, which is our, I don't know what it's called, but I was able to tap into that, and then we will record, myself or my assistant, Stephanie, we will record veterans or spouses or family member that came in seeking help or seeking guidance if we couldn't help them. The program last year wasn't really good, so we tried to input information, but we were having problems. And speaking with Susan, we were able to work with IT to get the program revamped, and it's a much better program now. I call it Vet Tracker. That's what Stephanie and I decided to call it Vet Tracker. So what I have here for you folks is the report for the whole year of 2018. And then I have an updated report for 2019 up to the end of August. So if I may, I'm just going to hand these out, just for a point of reference.
Thanks. If you just want to pass it, and then you could tell us about it.
Yes.
And while we're waiting, can I just, you mentioned you're going to training. You didn't say what it was for.
Mandatory training. It's like police officers yearly get updates.
Mm-hmm.
This is a training because I am under the umbrella of the state VA. I work under their organization.
So it's their informational update for your services?
That is correct. Correct. So it's basically the same as law enforcement, only for veteran service officers. It's
Okay.
a mandatory training.
Sorry, we're almost there.
And
Okay.
this is the 2019 numbers up to the end of August.
I think Bob needs one.
This is 2019.
Oh.
This is 18.
Here, come on. Well, I'd like to have one. Can I have one as the committee chair? Thanks. It's the one time I'm going to beg indulgence. Okay,
I
thanks.
do have an extra for 19.
No, go ahead. You need to read from them. Go ahead.
Okay.
I'll make copies.
There were two sets.
Yes, one for 18 and one for 19.
I have these.
Mhm.
Okay, so,
As you can see, the summary, it's based on the benefits that we help veterans, family members, and widows. It breaks it down on what they are. You'll see on 18 and 19, it has utility assistance, veterans ID card, VTA, the acronym VTA, that's Veteran Temporary Assistance. That is the program I spoke about earlier, that if it wasn't for rapid rehousing, they would have to apply for that. And that's the grant that goes through the state that can take weeks to get a decision on. So if you notice, they were a lot less in 18 because there wasn't really a need. People were not coming in requesting that type of help. And in 19, we have so far 11. And then you see call-ins, walk-ins, female, male, and the female, male portion is the veteran itself. We just wanted to have some sort of a statistic number on that. And you will see one, I know it says VA assistance not provided. What that means was someone came in requesting information or paperwork. They didn't know, they weren't sure what war the veteran served. It could have been a family member or even a spouse. We gave them the necessary applications and documents to fill out, and they never returned. But Stephanie was still able to get pertinent information, name, address, and things of that nature.
Did we reach out to them then? Like, if they came in initially, then left, did we try and contact with them?
We try. We try. I'm not going to say it happens all the time, but we do try. We do try.
Yeah, 'cause I just, one fear, that they're coming in with some kind of PTSD or some issue, and coming back is an issue. Make sure they don't fall through the crack that way.
No, but it's not the veteran itself. I'm speaking about family members, and they're usually about pensions. A veteran pension, which is just a stipend to help with medical costs, and a widow's pension, which is a stipend to help with medical costs. So it could have been family members, a widow that came in. We give them the information, and for some reason, they just never came back to us. And when you see the wars are broken down, you'll see unknown. That's a reflection of assistance not provided because they just didn't know which war they may have been part of. So that's where the unknown comes from. Obviously, a veteran's going to know when they served. So I just wanted to clarify those 2 points.
So it seems that you have a lot more contact hours this year than last
Oh, yes.
already.
Yes.
Is that because you didn't track it for the full year last year because of the glitches, or just it happens to be
There were
more?
glitches, and so it was, at times we didn't input the information. But once the program was corrected and updated, we're basically putting everything now, and that's where you see that large discrepancy, which is a lot more information that clients that are coming in, and hopefully we're assisting them in the best way manner. If we can't help them, then we refer them to other agencies. You know, like if a veteran comes in and he has a dishonorable, there's no way he's going to get any benefits from the VA. We won't tell them to leave, that there's no hope. What we'll do is, myself or Stephanie, we will refer them over to IRIS, Information Referral Emergency Service. They're on the same, they're on the same floor. We'll walk them over to see if they can help them, because we don't want anybody to leave and say, well, the county never helped. It's good that we just point them that way and let those who run those offices make the decision if they're eligible for any programs.
Go ahead.
So I think this is great data we have on. Now, what do you do with this information that you have? Like, do we change how we do anything to make sure we're targeting certain people? Or so while this is great information, are we doing anything with this data?
Well, we're going to try to do, as you said, sir, we're going to try to see if we can try to do more outreach if we're provided numbers with people that come in and then don't return. That's one of the things Stephanie and I will love to do, time permitting and having the ability to have some downtime and do that, because we constantly have people walking in for whatever reason. You know, that's the main thing I would love to do, to try to see if we can reach out to those who probably say, well, he's not going to qualify, so I'm not coming back. But you don't know that unless you submit an application.
Yes, I do.
People ask me, do you think I qualify? I never give them an opinion because it's not my program. It's the state or the federal VA. And people beg me, can you tell me? I go, no, I'm not going to tell you because I don't know. Let's just submit all the paperwork with all the required documents, and I tell them, hope for the best. I said, I never promise anybody that I can help them with, at the state or federal level. That's beyond my pay grade. That's not my responsibility. All I can do is get the paperwork in to the best of, complete it to the best of my ability and hope for the best. And of course, there are those that will be denied for whatever reason. But they have the ability to appeal either to the state VA or the federal VA, and then I will help them with that as well. I have been this year maybe 6 or 7 appeal hearings from appeals of veterans that were not happy with the decisions 5, 6 years ago. We're now going in front of judges now. So it takes that long. And I had one gentleman, and I'm not lying, we went up. He wanted me to turn around. He goes, Fred, let's turn around. It's not going to happen. I've never heard this in the 8 years I did my job. As soon as we walked in, the judge apologized to him, stating that he never should have been here. The VA never should have did what was done to him. Obviously, I can't say what it is, but, and I've never seen that before. But all these appeals are now catching up, and I've been going to either the Philadelphia regional office of the VA or the Wilkes-Barre VA Medical Center, because it's based mostly on video conferencing. And so far, I got a good record up there. Everyone's working. But again, we're giving the supporting documents now to help their case that was obviously missed when the application was originally submitted. So we've been good. It's been good.
You have a decent number of other. So are there any patterns that you have a good skew of the different things that you are doing, but there's like a certain number of cases that are other. So are there any patterns that you're identifying that could become another category, or are they just random questions? Like under this year alone, you have 77 other.
Okay. That can be any one of what I've mentioned. It can be they came in and we referred them to another agency, a veteran that came in. As I said, we walked them over to IRIS. or I was unable to help them for whatever reason, but I was able to get them in contact with Wounded Warriors or any of the other veteran organizations that are less strict than the state or the federal VA in terms of helping them with money. And these other organizations have stepped up and helped these veterans.
And the other thing I find interesting is that you have a category for unknown, that there's, you did a lovely breakdown of who's from what war, but then they just don't remember, or they don't know, or?
He said it's like when the spouse came in, or the widow, and they didn't know what war or something they were in.
Yeah. Okay.
Thank you.
Any other questions? Yes, sir.
Hi. The issue with the health fair you went to, the senior health fair? Did you
A
say
few
the
weeks ago.
Yeah, was it a veterans or a senior health fair?
It was a senior health fair, but because...
But the veterans show up?
Yes, they do.
Was there anything significant that happened?
People just came over. You can always spot a veteran because they're always wearing their hat, especially Vietnam War veterans now. As we will know, they weren't treated well when they returned, but now they're proud to wear that they're a Vietnam veteran. And most of them, believe it or not, most of them were clients. They just happened to live in the area and they walked by and they just wanted to say hello. And then we've had others who just had one or two questions, and I would hand them my
Did you
card.
present anything at those senior events?
No, I sit at a table like this. I have all the
So they have a place to reach out. They
That
can
is
come
correct.
in, and if they got a problem,
Yes.
instead of coming all the way to the
That's
county
right.
building, and
Right.
they're there for the senior fair. Okay.
Right.
And the second question is the chamber program that you mentioned.
Chamber of Commerce.
Is that the first time you've ever heard of a job program?
Yes.
For veterans? Well, it's not. Go ahead.
If I may. It's to educate employers, not the veterans themselves, to educate employers so they can understand and can translate what they did in the military to see if it fits with their company.
Okay.
This is the focus of this group.
Have you ever heard of any other program similar to that?
Not locally,
Okay. Did you ever hear of that Building Trades Helmets to Hard Hats program?
no.
It's 15 years old. I'll get you some
Yeah, please,
documentation on that.
please.
What it does is it places veterans that come back
Okay.
in with the trades.
Okay, that's
So
excellent.
they have, they have skills. They
Yeah.
get up in the morning on a little alarm clock. They already have been trained in OSHA and other things.
Right. Oh, that's excellent. Yeah, I'd greatly appreciate that. I can place that information on my monthly newsletter as well.
And also, one last thing, I'd like to thank the county for these veteran cards, because the people that work down there in that office, when we came through, I came through with my dad, and he never got a chance to get his medals from Korea. And
Okay.
she helped him out. She
Yes.
helped him with the paperwork, and it came in the mail like a couple of months later. So
All right.
they're doing a great job.
Thank you.
Yeah.
Yeah, she's an excellent employee, Stephanie Young. She's great. She's leaving in 3 years, but she's great.
Well, they help you get your discount, because they always give it to active,
Right.
and they'll give it to retired. But if you just serve,
Right.
this helps you get the discount.
And when we first started the program, only 2 companies signed up to offer the discount, and that was it. But yet, we continue to give the card. And I've been told by a lot of veterans that they will present the card to a company that never signed up, and they will honor it, which I think is a great thing. And I tell them, if you go, tell them to call me so we can put the list up. I mean, why don't you have a list of 2 names? I would love to put a list of hundreds of
I think Montgomery
organizations.
County was the first one.
Yes,
to do it.
yeah, and then Montgomery, and I just followed their template. Montgomery County has like, not Montgomery, Monroe has maybe 100 or 200. I would love that, but I can't force owners of businesses to become part of this unless they actually want to. Yes, ma'am.
Do you ever reach out to businesses and ask them if they'd like to be part of it?
When it first started, yes. And it started a year or 2, no, I think in 17 I may have started.
2017?
I believe so.
So it only started 2 years ago, and you reached out to businesses.
In the beginning, yes.
And when you did, what did they say?
A lot of them say, no, we don't offer anything for veterans. And especially the big ones, Home Depot, Lowe's.
But
Because
they-
they
Well,
want it.
But they
I
did.
thought Lowe's did,
They both did.
and now Home
Mhm.
Depot offers every 3 times a year or something like that?
Right, that's on the 3 major
Yes.
holidays.
Yes.
But we were hoping to get them to do it year-round.
They do it year-round for veterans.
They do.
And
Well,
Lowe's.
If
That's
they
right.
have, and correct me if I'm wrong, but if they have the federal identifications, and then it's issued by the federal VA,
I just signed my DD 214 in and they took it.
Yeah, I'm just asking
Yeah.
because, like, sometimes when I go to a place, they ask me if I'm a veteran to give me a discount. Like, they ask me,
right.
and I'm not.
It doesn't
You know.
happen often, you're.
And the
I'm
But-
flag on the license.
It's happened
too.
enough
There's
that
a
I
flag.
think that businesses would like to be
Patronized.
part
of course.
of it, yeah.
Of course.
So I just asked if you had reached out. and-
Yeah, I would love to do it again, but as you can see,
Yeah, you got a list. I got you.
because of this workload, it's, like, I'll be away for a week in October, and I'll have, I mean, and I'm expecting it, so I'm gonna have a lot of emails, a lot of phone calls. Stephanie will do her best to try to help them.
Maybe working with the chamber, since the chamber seems to want to partner with veterans, maybe they would be a good resource to make this list and reach out for you.
And I'm glad you said that, because I did that in 17.
Mm-hmm.
Spoke to the young lady who's now in charge of this program.
Mm-hmm.
She says she put it out there,
Mm.
and she never got any responses to all the businesses that are in part of that Lehigh Valley Chamber of Commerce.
Hmm.
I never got any calls. I know, I was the same way. I had that look of what's going on. Everybody wants to help, but when push comes to shove, when it's time to step up, they don't want to put it out there, and I don't know why. You're talking about income. I mean, who doesn't want their business to grow if you can get another population to come in and patronize your business? So
Yeah,
I'll
that's-
ask her again, because I should be seeing, I believe we have another meeting either September or October. Or I can shoot her an email or call her and see if she can send out another email to all the businesses to see if anyone is willing now to step up to the plate so we can add them to the list.
Okay, thanks.
All right.
Are there any other questions?
Yes, sir.
A statement first, with the chamber,
Mhm.
just a suggestion, get on their TV show. You know, I mean, they like to brag about everything they do,
Okay.
don't do anything. But if you get on their TV show, it's out in public, and,
The INL.
you-
Mhm.
yeah, put INL on the spot. So, yeah, I called, but I don't know, nobody, your members really care about what happens to veterans, what to do. I'm not saying you should do it, but maybe there's a citizen you know, a veteran.
Nothing like stirring the pot.
have-
Two other
have a
things
shot.
I had. The discharge status. And you said folks will come in that have dishonorable discharges. Do you let them know that, I know there were periods of time, and you mentioned Vietnam, and that was one period of time, where sometimes the discharge status can get changed. At the time of the discharge, someone may get a general discharge, not as much a dishonorable, or they might get a medical discharge.
Right.
And going back then and going through, let's say, the representative or senator, or even through Veterans Affairs, they are able to get an honorable have their discharge status changed. So if someone comes in with a dishonorable, do you inform them that there are avenues where if they want to appeal, if they feel they were unfairly given a dishonorable discharge?
Yes, I have the forms in the office for those
great.
that were less than 15 years, and then those over 15 years.
Good, I'm glad.
And I've had people come in, and when they receive the other than honorable
Yeah.
discharges, it's usually in lieu of a court martial.
Yeah, I know, I understand.
It's usually
But,
okay.
I mean, sometimes, and you mentioned Vietnam, and it was a crazy time, and I know of two people who had their discharges changed
Oh, great.
because it was just,
Right.
it was a wacky situation coming back. I mean, it was kind of crazy time.
Yes, I've given them the forms, and they have to fill it out because they need to put their side of the story.
And no offense, I know today we don't talk about it, but guys that were in, especially at that time, will tell you the military isn't perfect. It does make mistakes.
Right. Yes. I was in from 81 to 87, so I know.
My father was a combat veteran of World War II, and he told me when he got through basic and advanced infantry, I said, "What did you think?" He said, "They taught me just enough to get myself in trouble sometimes." I said, well,
yeah.
fortunately
That's
it
still
didn't.
true now.
Yeah, okay.
Trust me.
And the other question is, the Middle East, you know, we have the wars now. Now, you know, we talk about World War II, Korea, Vietnam era. But if folks come in, they say, I don't know where I served or what. Is there confusion sometimes with the theater they're in because of, I mean, we've been at war now for almost 20 years between Afghanistan, Iraq. Is there differentiation when they come in, or is it just a category?
They know, because if they were in the Persian Gulf, they will get the Persian Gulf Service Medal.
Okay.
If they were part of Operation Iraqi Freedom, that's the OIF, they get that award. If it's Operation Enduring Freedom, which is Afghanistan, that's when they discharge. But if they're in between them,
yes,
that's where they're classified as WOT, War on Terrorism.
Okay. Yeah, because, I mean, most of them are younger now, but I can see as you go down the road, just like you're seeing with Vietnam veterans probably, there may be some confusion, because if they served in one theater, but then they went and served another, because now their guys are being thrown in 3, 4, 5 tours of duty. It's crazy. So, I mean, they may not be sure.
No.
I was in 2, 3 theaters.
Yeah. No, they trust me, sir. They know where they were.
All right.
The medals reflected on their DD.
And we're prepared for the future on that, hopefully.
Yeah, I think the next wave of disabled veterans, and it's starting to come in now, will be the Persian Gulf, the oil field fires. I've gotten a few coming in with respiratory problems in the early 90s, and they're still in 20 years or so now. They're in their 40s, 50s, depending what time.
Yeah.
I figure another 10 to 20 years, they're the ones that are going to be coming into the office, like Vietnam vets with their Agent Orange. That's going to be that next large population of veterans seeking benefits through the VA because of that, and the exposure to the fires. Oh yeah, it's okay. But don't worry. They're miles away, but they can still see it and they smell it.
Well, that was the old statement with Agent Orange.
Yeah.
I have a relative who's getting benefits finally. Right. After all these years, they admitted that Agent Orange.
Yeah, they're now accepting. They're adding more and more disabilities now to the list. So that's the influx of Vietnam. That's why I'm getting that influx of Vietnam.
I'm sure. Thank you. Thank you. That's all I had.
We good? Thank you for your report.
Thank you, everyone.
Moving on, we have a report from Trinity Pharmacy.
Okay.
I just wanted to introduce Maria Manelli, who's our pharmacist at Trinity, and Jim Mooney, who's the MCO at Trinity for America. So they'll tell you and hopefully answer some questions that you have about Graysdale.
Good afternoon, everyone. Thanks for having us. It's nice to be with you. As Jen said, my name is Maria Manelli. I'm the consultant pharmacist up at Graysdale. So my primary job up there is to round on the units, to do medication regimen reviews monthly, and to ensure the compliance with the Department of Health and Center for Medicaid Medicare Services regulations. I work closely with not only the physicians up there, but the nurse practitioners, as well as some of the other partners, MedOptions being the biggest one for our psych services, to really do a whole team management of each and every resident on a monthly basis. We have each other's cell phone numbers. We're not afraid to pick up the phones and talk to each other to make sure we're doing the things we're supposed to be doing, taking care of some of our most frail, elderly, fragile neighbors. Trinity was contracted about 4.5 years ago to partner with Graysdale for their pharmacy services. We feel very privileged to be able to do that. We've offered several service enhancements, which have added benefit to the nursing staff, made things a little bit more efficient for them. We offer the 4 deliveries a day to the facility, which ensures timely medication deliveries. We added 12 stat safes to the building for emergency medication and first dose dispensing. And probably the best service we have up there is a full-time technician who's available during the weekdays to run interference between the nursing staff and the pharmacy, to handle the cycle exchanges, so that burden doesn't fall on the nursing staff, and some of the other day-to-day things that come up, prior authorizations being a big one for the insurance companies. like I said, monthly review the charts, but I also serve on several of their committees up there. I'm on the QAPI committee. I'm on the infection control committee, pain management, as well as the falls team. So within those committees, we look to, again, whole patient management. The therapists are involved in that. The dietitians are involved in that. So we really do an interdisciplinary approach to managing the patients up there. I provide the monthly clinical reports, which show a breakdown of their psychotropic utilization, their antibiotic stewardship initiative, as well as a breakdown of the number of residents reviewed and the recommendations that were made to not only the physicians, but the nursing staff as well. So in a nutshell, that's sort of what I do on a day-to-day basis. Like I said, I spend probably 14, 15 days a month up at Graysdale working with the team up there, and I think we're doing great things in reducing meds. Polypharmacy is a huge issue. They have CMS has a guideline, 9 or less medications they want to see as sort of the magic number. We know residents have a lot more than that. So I work, again, to reduce the number of meds that these residents are on, especially the unnecessary meds. Unfortunately, some of the disease states, especially your psychoactive meds that are required for your schizophrenias, your bipolars, we're not going to be able to get rid of them. It's more of a patient care thing than anything else. But those unnecessary meds, the supplements and things like that, we really have made great strides in reducing those numbers, as well as the unnecessary psych meds too. I work with the nurse practitioners primarily and the Med Options crew to help manage those numbers. And again, we've seen an incredible dip in those numbers. We even got recognition from the Department of Health a couple years ago for our efforts in reducing those numbers. If you have any questions for me, if there's anything else I can clear up for you, I'm happy to do so.
I know you said that they've made some changes and improvements. Do you have any other recommendations on things we could change or to improve going forward?
Well, one of the big things is happening right now, the new EHR with point-click care. I've worked with point-click care for quite a few years in several other facilities, and it really, truly is the top EHR platform a facility could work with. It's pretty much one-stop shop for the nurses, for the doctors, for myself. All of the information is there, and I really am hopeful that that's going to help them streamline not only their med passes for the nursing, but in terms of the nurses' aides, getting them more time on the floor to provide the patient care rather than the burden of paper charting.
Sure.
Just a quick on specialty drugs and the most expensive drugs and some of the legislative changes with the FDA coming down the pike. Do you see anything for any relief? Has there been any relief recently that you might want to talk about? Or no, I don't. You don't have to get in the weeds or nothing, but I just.
That might be more your speed than mine.
I didn't hear the question. The question was with specialty drugs, the most expensive drugs that we provide. Do you see any changes coming in the future with generic drugs, or saving money that way and getting the same quality? Or has there been anything in the past recently that maybe just curious? Because I know it's a big part of the spend over there, right?
Sir, could you also identify yourself for the record before you answer?
I'm Jim Mooney. I'm the manager of clinical operations for Pharmacy.
Thank you.
As far as specialty drugs, those primarily are known as orphan drugs. Not a lot of manufacturers going to make these, so you're kind of like stuck with what you've got. There are also some newer agents that have what they call REMS. It's a restricted program for dispensing these drugs. A physician has to register with the program. An example would be a drug called Clozaril, which was a couple of years ago. The physician has to register with this, the pharmacy has to register with this, so there's only a certain pathway that you can go to get this. The state of Pennsylvania, their Medicaid department has a list of specialty drugs that we can only get from 2 pharmacies in the state. So we're kind of restricted just in terms of that. So the resident in the facility has to go out to that pharmacy to get those drugs. We can't even get them in the pharmacy where we are. Now, as far as generic and items that are moving from generic to brand, there's a couple things that are coming out recently. Lilly just introduced an insulin product at half the price. It is the same insulin.
Probably using a lot over there, right?
Yeah.
Okay.
And that should be a good cost savings coming across there. And that's probably one of your top spends, insulin, because, you know, just judging from what I'm seeing, a vial of insulin on a retail basis is about $100, $120 cash. So you're talking a lot of money, you know. So we have some stuff coming out there.
The respiratory products, there's a few generics recently available for those, Advair being a big one for the treatment of COPD. There's a now, it's not technically an AB rated generic equivalent, but for your Ventolin, Prevental, HFA inhalers, they do make an albuterol HFA now, which is quite a cost savings.
Could she refer to AB rating? Maybe I should clarify that. An AB rating is a rating on a reference site called the Orange Book, which basically the FDA saying that this drug is equivalent to this drug.
Oh, right.
Unfortunately, the insulin that I was just referring to is not an AB-rated drug because it's the same product. It can't be AB-rated.
Right.
It kind of makes it a little bit weird, but the rating on that, it goes down through, there's BC ratings, BD ratings, and it goes down through, is what the pharmacy can substitute on a generic basis. So it tells us what drugs are the same based on the FDA guidelines. So that's kind of the background on that. The HFAs, the inhalers, and that sort of thing, they're not going to be AB rated because of the differences in the propellants and the other things that they put in these products. It's the same active drug, but it may have not a freon, I forget what they're using these days for the puff.
The aerosol.
So
Albuterol.
whatever that substance is, inert, you know, if that changes, then the drug can't be AB rated.
Thank
But
you.
that's one of the things that Jessica.
Pretty good news on the
Or-
Lilly stuff.
yeah.
Thank you.
That's one of the things Jessica does. We constantly are getting those prior authorization requests from the insurance companies, and a lot of times the insurance companies will tell us, hey, can you reach out to the doctor or nurse practitioner and ask them if they would be willing to try this generic equivalent or this cheaper brand name. So we run them up, talk to the docs, talk to the NPs, and usually it's no problem to switch it when it's something that's therapeutically equivalent. There have been a few cases, but again, those are few and far between, and they're very patient-specific depending on how frail or fragile the specific resident is.
Thank you for answering.
It's very interesting. You said that you determined unnecessary medications, you managed the numbers. And I'm curious, how do you determine and reduce unnecessary medications and manage the numbers without interfering or causing discomfort for the patients?
Well, what I do is I make a recommendation. So I look at a residence chart. I look at several things. Their different comorbidities, their age, their allergies, their lab profiles, a whole bunch of different things. And then I make a recommendation based on the clinical guidelines out there. Some of them are driven by Department of Health, CMS, but a lot of them are clinical recommendations that go to the physicians. It's always the physician's discretion to take the recommendation or to decline the recommendation. If they decline the recommendation, they usually provide a rationale, just to your point, may cause instability, may cause discomfort, not in the patient's best interest, and then the therapy stays.
Have you been successful in reducing the dosages by working with the doctors?
In some cases, yes, very successful.
That's all. Thanks.
So I have a question about on the same line. the state wants us to not have psychoactive drugs. It wants
Yeah.
us not to have pain meds, yet these people come in on a whole regimen. And what's the distinction in the state guidelines between what they need versus what they don't? Because I realize some of these psychoactive labeled meds are really used for pain management or for something else. So how do you specifically work with that challenge?
It is a challenge. In fact, I had a conversation this morning with one of our physicians up there. The residents that are coming in on the psychoactives are generally the residents that truly need them. Graysdale services probably the most fragile members of the community, the residents that don't have any place else to go. So unfortunately, those residents coming in tend to have the psychiatric diagnosis that require those medications. Reducing them is detrimental. And it's not only harmful to the resident, but it could be harmful to other residents or the staff. So it's a balance. And we work very closely to distinguish which residents are appropriate for those gradual dose reductions, GDRs, as you may be aware of that term. And in a lot of cases, we're successful with the GDR attempts in those residents that truly don't need the psychoactive. Maybe the little old elderly resident that developed a UTI that got sent to the ER for a mental status change, got very agitated, came back with a benzo, didn't necessarily need it, got rid of it. Those are the success cases. The pain management team looks at other modalities other than meds, and usually meds are our last resort. We try therapy, we try activities, we try just simple redirection techniques, getting them up, walking them around, taking them to the bathroom. Meds are really a last resort for that team and for the falls team when we have residents that we call the frequent fallers. We look at them and we look at not only their med load, but what else is going on? Are they bored? Are they hungry? Do they need to go to the bathroom? So 9 times out of 10, when we do a med reduction, they're very successful, and the med stays off the profile, and we consider those successes.
Can I interject? In that process, and I just kind of like, just to fill in background a little bit here, diseases in general are dynamic processes. They're not static. You don't get a dementia and stay with dementia. You go through phases where you need drugs and you don't need drugs. And obviously enough, we want to get them to the point where they can manage their lives without having to pop a pill. And that goes for any disease, pain management as well. Pain is a process that you go through. Generally, you have pain, you heal, you don't have pain any longer, you don't need the medication. So that's what we look at when we're looking through it. Is this drug is it continued to be given to the drug patient because of a comfort level with the patient? I have to have this, I can't deal with life without it. Or is it something that's actually physiological and, we can go through that. The other issue that, when you bring up unnecessary drugs, there's an actual specific list. It's called the Beers List. The American Geriatric Society puts it out. And those are the drugs that we're referring to when we're talking about unnecessaries. Sometimes those drugs are very necessary, and you can't get around that. As an example, a drug called oxybutynin for bladder spasms for people who have incontinence. It's on the Beers List, but if the only thing that works for this particular resident, we're not going to change it. You don't want to make them less of a person than they're already in a place that's unfamiliar to them.
So when the department comes in and they do their ratings, are they all or nothing? Like, oh, I see that, it's an automatic ding? Or do they look at the case profile, and then when you give a rationale such as you did, they go, oh, okay, then it's not a violation, if you will?
That is pretty much the way it works.
Yes.
They'll come in, they'll tag it, it'll stick up like a little red flag for them. And they do most of this now on the computer. So they're doing an iPad or Surface Pro, one of those things, and they're going down through check boxes. Depending on the answers they get, it's how far down the chain they need to go. So if they get 4 yeses, they can, they stop there and they go to the next thing. But if they get two no's and 2 yeses, then there's 4 more questions to go to ask, and they dig a little deeper. But they will come back to you and they will say, okay, this person is on this particular medication, why? And it's up to the physician to document why they're taking it, how long they need to be taking it, and whether it's continued, whether a continued benefit is there. So once that's justified, they'll move on to the next item. But that's part of what we do, because we'll prompt the physician for that documentation. And Maria does a great job on that.
I'm just curious. I've had a number of my family be at Graysdale and be treated, both for a number of reasons, okay? The nurses and the people that are caring for them come in, they make a statement. You have pain, if you give us an idea between 0 and 10 where you're at. If someone wants the medicine, they say, I'm at 10, and they're at 10 the whole week, okay, or a month, whatever it is. Has that been looked into? Are they still doing that?
They're still doing it.
I mean, it's just an observation, because I sat there and I heard the statement, and I said, it was kind of obvious, if you want it, it's a 10. If you don't want it, no, it's a 0, okay? It had nothing really to do with, there may be people trying to determine on their own whether they're in pain or not. Maybe they're in pain more than they don't even know it. But that, to me, seems to be a low spot on how to determine pain.
It is a low spot, but it's a common, and it's actually a way of measuring. Everybody looks for a benchmark. A pain scale of 0 to 10, 0 to 5.
That's a low bar for a benchmark, because you're telling the patient, okay, tell me, and they really don't.
What Maria will do, and what I do when I'm in buildings doing consulting, is I start to count the number of pain meds they use. I try to look at this to see what is going on with that. I see if they're combining those pain medications with any other medications. Just as an example, if they have an order for Ativan or benzodiazepine, and they're combining with a pain medication, that's a red flag for me. I'm going to talk to the doctor about that, because that is a common combination of drug abuse. And I've seen it happen with skeletal muscle relaxants and pain medication. So we do look at those, and we don't just take their word for it.
So you're saying there are documented cases where there are overlapping drugs that shouldn't be used.
And we look at that.
And you can find that rather easily if you go back and track it. And are you working with the dispensing programs that are on the hallway, in the hallways also, the machines? Where am I at? What do they call those things?
The stat safes?
Stat safes. Is that a stat safe, or is there another name for it?
With controlled substances, DEA is very specific on how this needs to be taken care of.
Correct.
Okay.
So every dose that's given has to be recorded on the MAR. So whether it comes out of a stat safe, whether it comes out of the resident's prescription,
Doesn't matter. It's all
it doesn't
recorded.
matter. It's going to be recorded on that
Okay.
MAR. We're going to see it.
Okay, so it's covered both ways.
Right.
And if we look at it, and this is an example, if somebody has a pain medication every 6 hours, which is basically 4 times a day, and they've used 120 of them in a month, that's a flag. It's telling me that something is wrong here. We're either not treating the pain appropriately,
Or the
but they
medicine.
shouldn't be
Maybe the
taking.
medicines.
And then we can go back and forth with that and try to fine tune things a little bit. I mean, that 120 is kind of over the top. You're not going to fine tune. You're going to take a baseball bat and hammer it back a little bit.
Okay. The 0 to 10 still bothers me.
You know who started that?
No, I don't.
Purdue, when they marketed oxycodone. And then it was adopted as the standard of care across JACO and across all hospitals. And that's why you see all the little smiley faces. But it started with the people that marketed
That's been-
oxycodone.
Is that going to be challenged?
That's your Jeopardy.
Is that
question.
challenged now that?
That can be called a dated statement, because if it started back in 1975, 80, 1980, maybe we should change things.
Well, talk
that-
to JACO.
But that's what I just asked. Is
Anyway.
that going to be challenged because of the recent, what do I want to say?
Opioid crisis?
Well, not only the opioid crisis, but so many challenges to like Johnson & Johnson, Purdue in the courts. I mean, you're finding that there's a lot of judgments placed against these companies because, yes, they were peddling these drugs for public consumption and not being very forthcoming with the side effects or the addictive qualities. So will that marker go away or be reevaluated as the standard? Because now you don't want people addicted to these things. So what Mr. Warner is saying is that you could very well just keep getting more drugs if you just say 10. Yeah, I'm at 10, thanks. Yep, keep giving it to me. Do you know what I mean?
Yeah.
It seems like obvious that somewhere that standard has to change.
Pain scales, unfortunately, haven't changed for quite a few years. There are a few different pain scales, 1 to 10 being the most common. The FACES is a scale they use for your dementia patients that can't really tell you what kind of pain. There definitely needs to be, in my opinion, better tools to aid
there has
the
to be some other
nurses
form of
for
evaluation.
assessment. But as Jim was saying, we look at the whole picture. We look at what is going on with that resident at the particular time. Are they like maybe post-knee replacement? And part of the control process that's been put into place is all of the controlled substance prescriptions that come out of the pharmacy get transmitted to the state on a daily basis. If there is an extra utilization flag, the pharmacy alerts us, and then we can investigate further.
Oh, interesting.
Especially if one particular prescriber is writing for an excess amount.
Are we good? Thank you so much for what you do and for coming here today and explaining it.
Thank you for having us.
Thanks for being part of the team. We have 2 things left. I'm pushing 4:30, so. Okay. I'm just doing a time check.
To follow up with Mr. Ramirez, he was talking about the rapid rehousing. I have a breakdown of the age divisions that use the rapid rehousing funds. As he said, it was funding through DCED. You have to be income eligible, so you have to meet the HUD definition of low to moderate income, which I will tell you the majority of human services folks meet that criteria, but are not eligible for funds directly from rapid rehousing. We had 6 different divisions that were able to utilize the funds. The VA being one, children and youth. Those folks have their own pot of housing money, but when they ran out partway through the year, they were able to utilize some of these dollars as well. And those folks, not only are we preventing eviction for the folks in children and youth, sometimes that is used to prevent placement of children into foster care, which obviously is preferable. Drug and alcohol use some. Our IRIS division, the Information Referral and Emergency Services, use the bulk of it because they are like the jack of all trades, right? So they field an awful lot of general calls. And then if there were folks who needed housing money but also maybe needed some additional services through one of our divisions, we were able to make those referrals as well. So as of the end of August, we had spent about $93,000 on that and served a total of 64 families or individuals. So that was exciting, and I know our IRIS folks were happy to finally have a pot of money to actually be able to help people when they called with these kind of problems, whether it's a $300 utility bill or first month's, last month's rent. It was very successful. So we're revamping it even further for this next year. We don't have quite as many funds, so we're going to make sure we take an even closer look at how we utilize those. Just finally got news that September is Suicide Prevention Month, so we have a few different things going on, but I got an article across my desk this week. They are now, it was approved for a 3-digit phone number. So we have the National Suicide Prevention Lifeline, and I have no idea what that number is, but there's a song, so if I could get the tune going in my head, I'd probably come up with the phone number. But it's not an easy phone number, and there's no acronym in there. So I think the number is going to be 988. So folks at the Suicide Prevention Task Force were very excited about that. Much easier to remember, and we don't need a song. So I don't know when that goes live, but I know it was approved through the government and all those channels. Along similar lines, I think we had this posted on the county Facebook page. The governor's office launched the helpline for grandparents who are raising their grandchildren and other kinship families. So you guys are in the know about a lot of things. I just wanted to mention that out there. They call it the Kin Connector Helpline. So safe to say, we talked about this before. I got a report this week. As of the end of June, there were, maybe I read this last month, I don't think I did, there were 23,000 tips that had come in. If I did say that, I apologize if I did. Only 1,300 were deemed to be prank reports, so very successful. Tuition waivers for Pennsylvania foster youth. So youth who are in foster care at the age of 16 or older are now, as of the fall semester 2020, going to be eligible for free college tuition in Pennsylvania, which is phenomenal. I know it's only in the last decade that they extended the age of which kids could remain in care from 18 to 21, as long as they meet certain criteria, or either in school or working. As we know, most 18-year-olds, let alone 18-year-olds who spend time in foster care, not really ready to be independent and on their own. So some really great work is happening in that area. The trauma collaborative that I've talked about, one of the grants that they got that we are working on rolling out is, I may have mentioned this, the Handle with Care model. So we're working right now with our DA's office, and there's going to be a training in October, I think towards the end of the month, for school folks and law enforcement. So when a child is exposed to some form of trauma, the police departments will be able to notify the school, handle Joe with care. It's called the Handle with Care model. So that way they're not saying what happened, but the school the next day can be prepared for that child to maybe have some behaviors or emotional struggles given whatever happened the night before, and they can handle them with care. So our DA's office, Terry Hauk and Tatum Wilson have been very helpful and are championing that effort with us. So we're excited. The Oasis Community Center, we've talked about that a little bit. It's our recovery/community center for family members, for folks in recovery. And the August recap, which was the July, is they were open, but really sort of a soft opening, and August was their first pretty much full go at it. And their guest and volunteer tally was 290 people. So really successful for the first month. And they each month put out a detailed list of when all of their support groups are. They had they hosted their first recovery dinner in August. September is also National Recovery Month, so they're doing some activities around that, and they're having a family recovery day on Saturday, September 14th for the whole day. They're having speakers and activities, so folks are welcome to go to that.
What day is it?
I'm sorry?
What day is it?
September 14th. It's a Saturday from 9 a.m. to 6 p.m. Mrs. Pennsylvania will be there as well, just
Well, we got to go then.
just in case you want to know.
And where is it again?
The Oasis Community Center. It's on. It's like 512 and 22. I don't have the. I mean, we can get you the address. I don't know that off the top of my head. In the old farmhouse. And one of the other things that we're excited about, one of the grants that Drug and Alcohol got for case management and assessments, we are utilizing one of the case managers every Thursday to spend a few hours at the Oasis to do assessments for individuals who would like to enter treatment, whether inpatient or outpatient. So we're trying to use those case managers and spread them around the entire county to make it easier for folks to access instead of having to travel further distances. So that is the other thing. And Haven House is continuing to just hit the ball out of the park at Graysdale. I just got a notice that they need 2 more computers because they have two more staff they've hired to add. So they're just continuing to do a really great job. That is all that I have today.
Thanks.
Great.
Questions?
My question? Nope.
Okay. And just in terms of, Mr. Dietz and I had spoken in terms of courtesy of the floor a while back, and as I told him at the time, I can't even confirm or deny the constituent issues that he was addressing, but generally speaking, when we have a concern, a family member, we make sure that they go through the channels of communication within children and youth before they just contact me. So I assured Mr. Dietz that of the specific process that we would follow in any case, but unfortunately I can't provide any more specifics on that. So I just want, just wanted to let everybody know. I think I need an allergy pill. So thank you.
Talk to the pharmacy left. Sorry.
Pharmacy left me. I need
You're on your own.
Benadryl. Thank you.
Graysdale.
Hello. I'm going to have Brian pass those out. So while he's doing that, I just want to say again, I know it's been in the news. We had a public announcement about it, but we did get our 3rd star. Yes, which is very exciting for us at Graysdale. It's not going to stop us. We're looking for 4 and 5, but we're glad we're at number 3.
Thank you, Brian.
I also wanted to reach out and let you know how great a job, again, our nursing staff is. We just went live with our orders with point-click care, and the RNs, LPNs, and my unit clerks have diligently worked their tails off getting all the orders transferred from one system to another. It was a very tedious project, but it is complete, and they are all live.
Well, this is a lot more fun to look at than the
I
other
know.
thing.
That's what I was like. You're like
That's
taking
much-
notes from the Lehigh Valley Planning Commission on your marketing of your program now.
That's it. I also did want to remind you about Family Fest, which is next Tuesday. 4 o'clock it starts.
Is that rain or shine, or is there a rain date?
Rain date is that next Wednesday, the Wednesday after it, so Tuesday, Wednesday. Last year was only the second time we had to cancel it. So we are fingers crossed that we don't. We heard a lot of complaints that we had to cancel it because of all the rain we had last year. Yep. So if you want to take a look at the report, the new report, so you can see is the census for July was 644. I am happy to report that I did get some August numbers, and we're looking at 653, and as of today, we are 662 for our census. So numbers trending up. Yes.
Oh my gosh.
So you can look at the hours per resident day. Again, we're at 3.34, holding steady at that. Cost per resident this month was $256, with the average being $372. The monthly all-inclusive Medicare rate was $453.39, with the room and board averaging about $367.29. You can look at the next page, which goes over some finances.
18 less.
You can see the revenues. We're down a little bit, and that was because of our census, but we are hoping in this last couple of months we're going to regroup, gain ground. Expenses were, again, lower census. Our expenses were up for this year. We're looking at making improvements. So the capital spending, we've been on equipment, resident furniture, the nursing call bell system, paging, and electronic health records, as even the pharmacy stated, is just phenomenal. The Graysdale admissions and discharges for the month of July, we had 33 total admissions, 121 inquiries. So again, we're looking on the upswing.
I
Very
have a
excited.
silly question about that. Like, so hospital discharge is one, but if they come back in the month, then is it recorded somewhere else that they come back?
No,
or is
that
it like,
is totally, they've discharged to the hospital and they're not coming back.
Okay, thank you. Because I know people get sent out for different.
Yep, those figures are not in here. On the next page, you can see staffing and call-outs. We've hired 26 new employees and terminated 14 employees. Of those 14, they were still people who were not coming in, a lot of per diem people who weren't helping us anyway, so they just decided to leave. Call-outs year-to-date, you can see are 3,631. Of these, 26%, or 952, have been FMLA or IFMLA. This does create barriers for us, but we are hoping to overcome them through different efforts between the county and also us in our hiring. Our recruiter has been phenomenal. She's already hitting the ground running through HR, so we're hoping to see some more advancement with hiring people. Workers' compensation, you can see the lost claims. There are 4 claims for July. They were down from 5 claims in June. Numbers of days lost was down, 124 for July compared to 148 days in June. Safety first is always our #1 goal for the residents and the staff. Safety is always. Modified duty, there were 7 claims in July, down from 8 in June. The total number of days was 121, down 42 days from the month prior. Wounds, infections, and treatments. So if you look at the wound care, we were up by 1, so there were 55 wounds, and that was over 51 residents. We've healed 20 wounds. 15 wounds are no longer being tracked due to being discharged or the resident has passed. We're working on the team approach. That's where point-click care comes into it. We're working to get the iPad so that the wound team can look and monitor the wounds in active real time, see how they're diminishing. We're very excited for this. We're hoping to go live soon in the next 2 weeks. Infections were up a little bit in July. Season, summer colds. So it was respiratory and skin soft tissue infections, but again, we're working on them. Then we go into the incident and falls. So again, we are always conscious of our falls and medication errors. The falls, so there were 168 falls. So of that, there were 60 repeat resident falls. So that was 108 residents that had falls. Training is the key to keeping incidents low and bringing Greysdale's rating to improved status. Greysdale staff development continuously works with our floors and units to make sure that we approach every incident, whether it be a fall, a care issue, that people are retrained. We're looking at every aspect of everything in our nursing home. The resident-to-resident assaults are down, and the resident-to-staff assaults are down. And the last page goes over the quality measures. So you don't have that graph anymore, but we did want to point out that we are better in 7 areas than the state, and we realize what are 4 main areas that we have to work on, which is always the moderate to severe pain, the antipsychotic medications for both long and short term. That is something we're going to continuously have to work on.
But the wounds are improved.
Yes.
So that's excellent.
Mm-hmm. Every day we're getting a little bit closer. We're doing a great job there.
So when we're above the state average and they come and they rate, I assume you do a quality improvement plan with them or an action plan?
Right. We have, and that's part of quality, QAPI. We have performance improvement plans that we continuously work on. We self-identify and try to tackle those problems before it's even identified by the state.
Excellent. Thank you. Any other questions or comments?
I just have one more thing.
Okay.
Oh, no.
Oh, The census.
Yes.
At one time, and I don't know if this is still the case, there was a bonus if your census was above a certain percentage. I'm not sure where we are, but I see a couple months there we were significantly below our target. So I guess my question is, does that census bonus percentage still exist?
We've always been, it was always at that 92%. That's for the, I can't think of the name of it, but Brian can.
One of the things that is predicated on our census is what's referred to as the DISH payment, which is disproportionate share. And what that is it's our percentage occupancy of MA residents. And every year the state comes out with a scale, and based upon your MA percentage that you report on your cost report to the state, they have a dollar figure per day, and that's where your payment can fluctuate from year to year based on your MA occupancy, not your overall facility, but your MA occupancy.
Now, my question is, we don't have that broken down here, but that, I was here when, things were bad. That was one of the issues. When the census went down, we didn't hit that bonus, and that, you lose. Not only are you losing from not having patients, but you're also not getting that bonus for meeting that. And so my concern here is, when I see these lower census numbers, are we in danger of not only losing the revenue from not having the census as high as it could be, but are we also in danger of potentially losing that bonus money for, was it 90 or 92%? Are we anywhere, is that a concern that we have right now?
No, not really, because also, too, it's with the DISH payment, I believe you have to have at least 90% occupancy. So for us, we'd have to be down a little over 68 residents from 688, and we haven't dropped that low.
We've been running about 94%, even in our low time of 40 beds. So we've been diligently working, and admissions has worked very hard to get it up to 662.
Okay, and one of the problems that we always had was at one time there was a waiting list. And so there never needed to be any marketing of the facility at all. And so it came as a shock that, what do we do? So I guess my question is, to what do you attribute the census decline that we had there earlier this year, and what are we doing?
The positive news that we've had over the last couple of months, last 2 months, between the star rating and just getting out there, has improved everybody coming into the facility. Unfortunately, at the beginning of the year, we were hit with the state and the deficiencies. Then there was some articles and newspaper information that hit home. There was the question about striking that hit us. So there was a lot of bad publicity for the first couple of months. And then that had to die down, and now we're reaping the benefits. Just last year, we had a wait list. I could not find male beds anywhere. I couldn't make a male room at Graysdale. So it was a happy problem to have, and we're going to get there again.
Okay.
And while Brian is up here,
We have one more question.
Yeah,
before.
and since Brian is there,
Okay.
I have a question. The fact that we are losing some revenue this year, okay, right now, is that cutting into the IGT funds that we are lucky to have to keep us floating?
Our census hasn't created that situation. Every year we do use some of the IGT funds. Just for comparison, 2018, I believe our total net gain was around 4.7 million, and our net income ended up around 3.4. So, we do use it, and it does help the facility to not be in a loss situation. But this year, even though we have had a census drop, we're not seeing that situation, a loss at this point.
Okay, because one of the numbers, it looked like we were down 2 million. And we
compared to
last year. Yes.
But it is still not creating a loss situation.
Okay, so, and we are above, the IGT money was higher this year, correct?
Correct.
It was above 2.7?
It was approximately an additional $2 million.
Okay.
It was around 6.5.
All right, so really, okay, let's take the IGT factor out. Okay, where are we financially right now? If we didn't have that, where would we be?
take the 6.5 out, we would be in a loss situation. But in prior years, it is a similar scenario. If you take the IGT.
Oh, it was worse. John and I sat through a lot worse. Trust me. Okay, I'm just curious to see if we depend on the IGT funds now every year.
Correct.
And I'm trying to see where we are realistically with numbers without the IGT. If we can hold our own, or if we'll be in a red situation again.
The IGT money, we have the IGT funds, so I don't see a red situation. If IGT funds were to go away, you know, there may be some other.
I don't think they'll go away, but I was just curious.
Right, yeah. And like to your point, we are fortunate to be involved in that program.
And we continue to keep the census built, and we will continue to build it.
Yeah, there was substantial money in that census. There's substantial. It was $200,000-300,000, maybe $700,000. Okay.
Okay.
Just one quick follow-up on that, on Mr. Werner's comments. The issue here, and this goes to the state more so than you, is the Medicaid reimbursement rate has not kept up. And what they've chosen to do is use the IGT to make up for that. And as long as that continues, we should be in a good financial position. But should they ever go back to the way things were, we'll be right back. My opinion is we'll be right back in the hole. I think the solution is to increase the Medicaid reimbursement rates to where they should be to keep up with inflation.
Agreed.
Thanks.
So who are you going to call about that? You got some friends that I don't know about? Sorry.
But
You had one more positive thing, and Mr. Heckman had a question.
Well, two things. One is, yeah, I think one of the problems we had, because I remember over the years, we were doing fine and we had waiting lists, but then the Private Home Owners Association flexed their muscles in Harrisburg, and that's when the rates changed. And the private home said, now we'll make more money, so we'll take some of those people that they never wanted to take before. So now I think that's been changed and that evened out. So there was that dark period for county homes that was the private market somehow not being so private and flexing their muscles and getting preferential treatment. Having said that, I guess the other thing I wanted to ask you was your private home association, and I know you have that. I mean, not private, public county homes. I don't know. I know there's fewer now than there were before, but you still have a few homes out there.
Correct.
Are you actively going at the legislature or trying to promote the idea of what's been talked about here, that the trends are that county homes will be the place of last resort for many elderly with multiple mental and physical disabilities, and that, you know, it's still a lot cheaper for the state to look at that and make some kind of adjustment for you folks than it would be for us to be screaming, we need another small state hospital, we need specialized. So, I mean, I just wondered, is that an active topic that is being discussed by county homes?
Yes, and I'm on the committee for that, so.
Great. So, thank you.
Yes.
We've been talking about this since 2015. I'm sorry, thanks, John. Since 2015, we talk about the funding formulas. That's what you're talking about, Mr. Heckman. We're talking about the funding versus private versus county-owned.
Yeah.
And those were changed. So you have to keep an eye on the ball to make sure that that doesn't change again, because that could change again. And if that does, then we have to rely on some other sources. And being creative, are we looking at other sources for
income?
Mm-hmm.
Yes, and there's going to be a change coming with PDPM starting October 1st. It's actually going to be a more fair way of getting paid, because it's not going to be therapy driven. It's going to be comorbidity driven. So you're going to get scored on people's diagnoses, you know. So we are hoping to reap the benefit of that, because we do have the more sick patients.
Okay.
So,
Real quick.
you get the last word. How's that?
Thank you. So Brian Dunlap the lead accountant has accepted the position as the assistant nursing home administrator.
Oh, congratulations.
So I'm going to let him tell you about himself.
Here's your big minute, Brian.
Well, as you know, I've been here a few times. I'm the lead accountant, transitioning into the assistant administrator. I've been with the county 2 years. In the past year, I have taken college courses at Marywood University, which is one of only 6 or 7 universities in the state that is granted the permission essentially by the state to have a program that they call the 120-hour long-term care course, which is actually a prerequisite for nursing home administrator licensing exam, which obviously my intention is to sit for. And I have completed that course, and I'm just happy to have the opportunity to further my career and grow within Graysdale and Northampton County.
Thank you.
Doesn't NACAC still have that, where you can get a nursing home administrator? NACAC had a full-time, you went for a week for like X amount of hours, but it was a full-day deal, and you could get a... Oh, they don't have, it's not nursing home administrator? That's where I thought Skeeter went. Okay, thanks.
So you have to hire somebody as good as you to be your successor as lead accountant, okay? And with that,
Yeah.
hey, you took the job, now find a guy. All right, thank you so much, congratulations, and with that, we will adjourn this meeting. Thank you.
Let's go.
It's almost as bad as an energy environment.